Thank you. So we have about 10 minutes for conversation. I'd love to take up, but I'm going to just put it out there and others can comment. But I actually, the tension that John raised about and Molly actually, it sounds like in the 1B discussion, was there's segmentation happening now by lots of folks. What's the advantage of a more standardized topology, bringing some structure and order? How does that, because it really does look different. So it's not just payers, but as Molly said, other systems, but managing that tension. And is there value in driving toward a shared typology? And if so, what is that value? And how, I think we've established it for clinical care. It's actionable. It's for the patient's benefits and for value. I think people would agree with that. But there is this real tension of there's lots of segmentation happening on lots of dimensions today by different folks. What's the contribution here? So if I'd talk about that for a few minutes, or whatever else you'd like to talk about, but I thought that's...
I just wanted to add that I think that to the comments that I've made in our smaller session, that I think that a lot of this has to do with the earlier point that Melinda and others have made about who you're targeting. That some of the standardization of this segmentation will be very important for policy purposes, for state reimbursement and federal reimbursement purposes. It can be very useful. At the provider delivery system level, there really are two parts to that world. The part of the world that's already embarked on this quite heavily will find this helpful because it will suggest things you haven't addressed or potential utility that you wouldn't have picked up. But for the people or organizations that have not really embarked on it, if you got the policy changes and the reimbursement changes to drive more directionality, they will find it very useful because they're the people who are the late adopters and they want something that's packaged and ready to pick up. So I don't think the question is whether it's useful, but it's understanding the different lenses of the groups, and that particularly with the delivery systems that are out there now, they're already making strides in large enough way that I hope we have a very strong two-way street of learning from them as well as developing our database approach.
So if I were to respond, or I will respond or try, I would say, one, I don't think it's happening quite as much as people think. That's not to say it's not happening. And I think, so we, as part of Jerry's grant, and Cynthia might have been on that team. I don't see Jerry. I don't know if Cynthia's in the room. They actually did a whole bunch of interviews with people, with health systems are programs about kind of the targeting piece of this. And then when they looked under the hood and they asked them more questions, it was a little more idiosyncratic. It wasn't quite as systematic. So there's that. Speaking to kind of the late adopters and the laggards, like, well, maybe so that's one. Two, it's great if it's happening a lot more than we think, because then we could learn some of the best practices. So it's still worth it to actually further investigate, synthesize. Three, when Ashish, he talked about how he had an advisory group. When he presented his this was a prior version of his segments, to his advisory group, they weren't that impressed, to be honest, because they were like, well, we're using much more sophisticated systems, and we've got clinician input and patient input and all this stuff. But it was really like he was talking to group health, Partners, and Kaiser, and it was a very rarefied group. He's like, okay, so maybe I need to widen my sample of advisors. So I guess my view is that a statement, by people around this table about value and approach, and then also maybe thinking about kind of learning more from some of the best practices, I think could only help to further iterate, further improve this approach.
Yeah, so a little bit more about that aspect. So our group, I think David did a good job of capturing this tension about, how much rigor do we expect in these approaches? How much are we willing to sort of, what are the goals of the segmentation and how does it trickle down? I think we heard a lot about sort of trying to keep the innovation going, recognize the groups that are doing it already. But I think that that's fine, I think, but we do have a lot of sort of data and analysis illiteracy, even at the highest levels of many organizations. People, especially in health systems, do not rise to their position by being really good necessarily with data and numbers and understanding this and understanding the way that affects their analyses. So if nothing else, when I think about this as an informatician, all these sort of nuances about the data and its potential value, but to help inform the future healthcare system, not the one we have today, one aspect that I don't think we've hit on as much is the need to really identify ways for people to become more familiar with those major gaps or issues or opportunities that come as you create these segments, as you try and advance your data, as you try and find new data, and to try and bake that into the policy and then encourage that sort of uptake at this level. And if nothing else, this decision and this discussion and all these nuances can kind of move us along that track. When we tried to replicate predictive models at our own institution, one group called the Business Intelligence Group said, we're just going to use this one. It exists. It's great. We actually validated it and got about, a third of the power that they had initially reported. And so that kind of understanding needs to be sort of part of the structure because of that variance that can occur because of the data. I think that's very helpful to have this discussion.
Steve?
I just wanted to make a couple of comments. One, to enhance on the functional status measures and bring up the idea of whether functional status ought to be a cross-cutting issue like behavioral health, as opposed to maybe just embedded in the frail elderly, as the impression I've had so far. Functional status, if someone needs help in their basic activities of daily living, bathing, dressing, toileting, that automatically brings in a caregiver, family supports, living arrangements, etc. And so these kinds of things call for an integration of medical and social care and have implications for long-term services and supports and integration of care services there. And that could be for, I think, people in any of the segments that we've talked about. The second point I just wanted to make is that individuals are going to change segments. And this may have more implications for our discussion this afternoon, but if we're looking at models of care and knowing and hearing how important it is that patients, older people in particular, trust their providers and their caregivers and develop a relationship with them to enhance their achievement of their health care goals, that if we have a model that's good for one segment, but then someone changes segments and becomes end of life, suddenly they have to go to a different model or something, or a different team. I think this has some implications that we've been talking so far, I think, assuming people are in one segment and maybe not discussing as much that people are going to change segments as defined as we have it. Thanks.
We have a couple more minutes. Anyone want to amplify other thoughts that you'd like to capture? Because we're going to shift gears in the afternoon actually to talk about design elements of the system. So this is really about the morning started with the patient, family, and we're going to shift gears. So any last thoughts, amplification, things that you don't feel like we've covered or you'd like to clarify, and then we'll, Peter.
So I'll add to what Steve just said about changing segments and trusting relationships. In the breakout, I talked a bit about trusting relationships, which I think really are a critical aspect of this business of advanced chronic illness care. If you're really sick and you've developed a trusting relationship with a team of people who've done a good job of taking care of you, my experience has been with my patients and their families that they really want that relationship to persist essentially to the end of life unless they get miraculously better. They don't really want to give up that relationship and that team. So as people move between segments, let's say become a hospice patient, they need palliative care, they don't necessarily want to give up their established provider to fit the model of the palliative care template unless their provider is unable to deliver that. So I think we should be careful about artificially creating barriers to continuity in whatever we design.
Okay, John.
A little bit more on that tension piece. I think whether you're a provider or a payer, how you react to this discussion is very different if it's being presented to you in an instructional way, in an incentive-based way, or a regulatory way. So if someone came to us and said, we'd be very curious, what do your PMPMs look like if you looked at them across these buckets as opposed to HCC or DXCG, and do your care coordination programs yield a better, worse, or different ROI based on this discussion, right? That could be very instructional to us and very helpful in getting our thinking around a different mousetrap in the way that we're currently doing risk adjustment or risk stratification. If someone came to a provider or a payer group and said, hey, we're curious, we'd like to design a challenge around improving care and lowering costs for this type of population, do you want to get into the game? That could sort of elicit a different response. If there was a state or federal law that said you must offer these 3 types of care coordination programs to people in these segments, or you shall never offer this to that, then that would obviously elicit a different reaction. So again, I think it's how this is all framed and offered to the different segments where I think it matters. And then I can't sit here and look at Joanne and not think about the relationship between transition, segmentation, and measurement. If there are requirements, particularly as CMS and others are charged with developing new measures for care coordination and other types of quality, you would hate to see, because you're measuring this or have to measure this, someone would be required to or not able to access something that's available to one segment or another. But I hadn't heard measurement come up specifically in regards to transition.
Great.